Hello, good afternoon. Thanks to NUCD 2024 for inviting me for this talk, and in particular, thanks Professor Alokanungo for giving me this opportunity. And I have a very exciting topic, Dapagliflozin, SGLT2 inhibitors, as the first-line therapy in the management of type 2 diabetes. I am Dr. JJ Mukherjee from Kolkata. Sorry, I overshot. So let's start with the case of Smith. A 49-year-old male, IT engineer, smokes 10 cigarettes per day, 120 to 180 ml of alcohol per week, permissible. Obese, detected to have diabetes 3 months ago, HbA1c is 8.6. Hypertensive on A2RB and CCB, not well controlled. LDL is 143. On a statin, dose you might take whatever you want to take as the dose, maybe 20 milligrams. No DR, no nephropathy, no peripheral neuropathy. ECG shows an old anterior wall AMI, Q waves from V1 to V3. And a 2D echo requested by his treating physician shows an LVEF of 42%, which is have a ref with reduced ejection fraction. So question is, what are you going to do? How are you going to treat him? How are you going to approach him? Are you going to think about an SGLT2 inhibitor or a metformin or a GLP-1 agonist? Answer is no. You have to think about holistic care first. So for this person, glycemic control, yes, is important, but prior to that, we need to get his blood pressure under control. We get to get the lipids under control. We need to have at least a 2 to 3 minute conversation in our first visit about how obesity is not good with regards to all the metabolic issues that he has. And we have to have a kind of a conversation with him regarding quitting smoking. After we have done that, we need to think about getting the glycemic control. And we cannot do all this on our own. Physician is only 1/4 of the whole treatment armamentarium. We need to have a dietitian if we can, some trainers, motivators, and diabetic nurse educators who will keep reinforcing the education. As you know, majority of the treatment is diabetes, education, education, and education. So now when you've dealt with the hypertension, which is not too difficult, but not easy, once you've taken care of the lipids, once you have talked about obesity, quitting smoking, you start thinking of glycemic management. And when you start thinking of glycemic management, you need to know the pathophysiology. I grew up with the traditional triad with increased hepatic glucose output, decrease in insulin secretion and insulin resistance, and then Defronzo in 2007 in the Banting lecture added a few more, where you have the incretin effect and you have the increased glucose reabsorption, which is called the ominous octet. So whatever treatment we start to give, we need to make sure that we're dealing with these pathophysiological defects. Otherwise, we may not be getting a good outcome in the longer run. So my topic is first line. I mean, this first line, second line, third line is not an outdated concept. Why is it outdated? Let's go through the various standards of care of the American Diabetes Association, which are based on the various ADA ESD guidelines. Now, this is way back in the year 2016, metformin, followed by a second line, a third line, and then a combination injectable therapy. So be it. Come to 2017. Again, they say start with metformin. That's the talk. That should it be metformin or should it be an SGLT2 inhibitor? Then comes dual therapy, metformin plus SU, TZD, DPP4, SGLT2, GLP1 or insulin, and then go on to triple therapy when you are not able to get glycemic control with dual therapy. Come to 2018, looks the same. Monotherapy, dual therapy, triple therapy. Now, when you come to 2019, things begin to change. Why? Because by now you're getting the data, the EMPA-REG outcome trial, the Canvas trial, that are beginning to come into the picture. And now what they do is there's a sudden change now. If you go back here, instead of putting everything in one basket, you're now dividing them into those with established ASCVD or CKD and those without established ASCVD or CKD, and then you're putting them into groups, compelling need to minimize hypoglycemia, compelling need to minimize weight gain, and cost is a major issue. But still, in 2019, if you see on the top, it still says first line therapy is metformin and comprehensive lifestyle modification. Don't forget that. Professor Alokanungo keeps stressing that, and I agree with him, that lifestyle modification has to be on the top. If you want to believe in this first line, second line, then I think the first line is lifestyle modification. Now let's come to 2020. What happens? Looks almost the same. Again, have you got any organ-specific issue? That's type 2 diabetes with ASCVD, CKD, or heart failure comes in now. But remember, heart failure or CKD are in the same box here now. And they're the same three things. Company need to reduce hypoglycemia, weight gain, or cost is a major issue. Coming to 2020, now if you see heart failure and CKD separate out, because by now more data is coming about SGLT2 and the CKD benefits. So now, instead of in the previous year, where heart failure and CKD was in the same column, they're now being teased out into ASCVD, heart failure, and CKD. But on the right-hand side, people who do not have established ASCVD, heart failure, or CKD, they still remain as they are. Hypoglycemia, weight loss, or cost is a major issue. Now you come to the next year. What happens here now? Now here, if you see, first-line therapy still is metformin, but the line has now changed. First-line therapy depends on comorbidities, patient-centered treatment factors, including cost and access considerations, and management needs, and generally still includes metformin. 2021, 2022. Here the boxes are still the same, ASCVD, but they get a little bit more elaborate now because they're getting more data with SGLT2 and GLP-1RA. And on the right-hand side, looks more pleasing to the eye. Hypoglycemia, weight loss, and cost is an effect. Now, the use of glucosamine in the management of type 2 diabetes, 2023. Metformin has disappeared from the top. Oh my God. Healthy lifestyle behaviors, diabetes self-management education and support, social determinants of health. And then straight away you're jumping into whether there is ASCVD. And now you see another big box, which is indicators of high risk. Then comes heart failure, CKD. And now if you come on the right-hand side, gone are those subdivisions, whether you want less hypoglycemia, weight gain, or cost is an issue. It all becomes only two columns now. Glycemic management and achievement and maintenance of weight management goals. And the same thing is the latest one, which is the ADA Standards of Care 2024. So what have I said from 2016 to 2024? The ADA Standards of Care, which most of us follow, which are inverted commas evidence-based based on the ADA, ESD, various guidelines, they have now gone up. The first line, second line, third line. So this thing about dapagliflozin should be first line therapy probably is a little bit outdated. Why and what we should do, I'll discuss as we go on. So I think what we should do is when you see a person with type 2 diabetes, you need to decide what kind of type 2 diabetes it is. I mean, all type 2 diabetes is not the common garden type 2 diabetes that we treat. Is it a LADA? Is it a type 2 diabetes with insulin deficient? Then the treatment is different. I think we have done all that. And we're not talking about common garden type 2 diabetic patient. So whether they have comorbidities, ASCVD, high risk for ASCVD, heart failure, or CKD. So the same gentleman now, we have taken care of the hypertension, hyperlipidemia, smoke. So it's high risk. Smoking, hypertension, hyperlipidemia, he's got ASCVD, and he's got heart failure. So for him, he's on the left-hand side of the treatment algorithm. He's got ASCVD, he's got indicators of high risk, not by age, but he is obese, he is smoker, he's got dyslipidemia, he's got hypertension, and he's got heart failure, which is compensated because he's walked into your clinic. So here in this situation, either a GLP-1 with proven CVD benefit, in most cases you can't use it because of cost constraints. So the easier option is an SGLT2 inhibitor with proven cardiovascular benefit. Now he's got heart failure, GLP-1 is not here. It's SGLT2 inhibitor. And if he's got CKD, which he doesn't have, then SGLT2 inhibitor score over GLP-1 receptor agonist. So if you think of an SGLT2 inhibitor, the best evidence comes with dapagliflozin and empagliflozin. Kana does not have this broad data with regards to the MACE, CVD, heart failure, and renal outcomes. And ertugliflozin is not available to us, so I will not be discussing. This is the DECLARE-TB trial, which showed that you had a statistically significant reduction in CVD, hospital, and heart failure in DECLARE-TB. And then when you sub-analyze the DECLARE-TB data, people who had an MI less than 2 years ago also had a reduction in the 3P MACE, and people with prior MI, which was about 40 odd patients, the people fell into this group. Now 60% of the people fell into a primary prevention group in the DECLARE-TB trial, which was different from the EMPA-REG and the CANVAS trial, that they only had multiple risk factors. And even here, if you see, they got a benefit with CVD, heart failure, or renal failure. So in this group of patients, people with established atherosclerotic cardiovascular disease, heart failure, renal, CKD, would you be choosing metformin or would you be choosing an SGLT2 inhibitor? And the answer is very simple. If you take metformin, as a first-line drug in patients with type 2 diabetes with high CV risk. This is from Dr. Abdesh's article in 2021. There is no evidence in head-to-head trial that suggests metformin is inferior to SGLT2 or GLP-1 reducing CV risk. None of the CVTs were conducted in the absence of metformin. No clear evidence exists that metformin mitigates the benefit, maybe slight, you'll see on the other side. UKPDS 34 showed significant reduction in MI and all-cause death, albeit a small number of 354 patients who got on metformin and the other 354 were not on metformin. But it did show statistically significant reduction in MI and all-cause death mortality. And meta-analysis of real-world studies found significant reduction in CV and all-cause death in patients with CAD. So in people with established CAPD, ASCVD, if you're using metformin, you get this benefit. It's inexpensive, minimal side effects, and many other additional benefits which you have with metformin, like anti-cancer and anti-aging properties. But if we come to the cons are available evidence of CV benefit with metformin. It's class 2A. It's level B evidence, as opposed to SGLT2 and GLP-1, where they have absolutely well-designed cardiovascular outcome trials with class 1 level A evidence. There might be some studies, some meta-analysis have shown that there might be some mitigation of CV benefits, especially of GLP-1 RAs and SGLT2s if they are used with metformin. But this is not sacrosanct. UKPDS 34 that showed benefit in MI and all-cause death metformin had minimal patients with established ASCVD, which I think is not negative. Maybe this is a positive point for metformin. Meta-analysis of RCT found no significant reduction in CV all-cause death. It's exactly opposite to the other side in the meta-analysis. There are a couple of meta-analysis which show benefit, and there are some which do not show benefit. And use of metformin alone might delay the use of these agents and therefore may deprive the anticipated cardiorenal benefit, especially in patients with high CV risk. I mean, so if you look at somebody with type 2 diabetes, like our patient, 49-year-old, who's got heart failure, who's got indicators of high risk and has also got ASCVD, I mean, you will be choosing an SGLT2 or a GLP-1, obviously, because it's got a class 1 level A evidence. But if you ask me, this is all absolute and unnecessary debate. I mean, I would be using both the agents because metformin also gives me the benefits in this group of patients. So I will use metformin plus an SGLT2 plus also other anti-diabetic agents because you see the HbA1c is 8.6. A metformin, a DPP, and an SGLT2 inhibitor may not get me to my glycemic goal of say 7% in this person. So this thing about which first, which second doesn't make sense. I mean, I would be using both together, and that is what we wrote. And this book is coming out with the next edition very soon. And we wrote that initial combination therapy is the way to go in a person with type 2 diabetes. Certainly in this patient, in the combination, an SGLT2 inhibitor like dapagliflozin or an empagliflozin must be there. Between DAPA and EMPA, nothing much to choose because you already had an AMI, so probably an EMPA may be a better option. But if you only had risk factors without an established AMI, maybe dapagliflozin would have been a better option. So what about the other group? Type 2 diabetic patients who do not have established cardiovascular disease, 32-year-old, IT, non-smoker, type 2 diabetes for 3 months, BP is normal, lipids are controlled, no renal failure, no retinopathy, ECG is normal. So it's falling on this right-hand side group. And here, if you see the guidelines suggest for glycemic management, use drugs with efficacy, high efficacy of glucose lowering, which is probably the GLP-1 receptor agonist and insulin, and SGLT2 inhibitors and metformin both come together into the high efficacy of glucose lowering group. And on the right-hand side for weight, if you see SGLT2 inhibitors are above metformin with regards to weight reduction. And to answer this question, there's a huge group of people, you will recognize many of them who will be attending this conference, who did a meta-analysis on SGLT2 as a first-line anti-hyperglycemic in the management of type 2 diabetes in the context of Indians, a systemic review and consensus. And what they found was impact on HbA1c same, glucose variability probably the same between SGLT2 and metformin. All the yellow boxes, beta cell function, insulin resistance, gut microbiome, impact on weight, impact on BP, impact on lipids, all the same. Some of them have got level A evidence, randomized controlled trial. Some of them have got level C evidence. Where it scores over metformin as first line is CV protection and renal protection. And if you come to combination of SGLT2 or metformin, again, as safe, SGLT2 combination with insulin and decreases insulin requirement, again, is as effective. This is a meta-analysis where this group of people went through all the published literature till date before publishing this article. So if you want to take the cost effectiveness, if it is a Western world, then probably it's different. In Western world, SGLT2 and GLP-1 receptors cost more. But if you come to India, probably the cost difference is still there between metformin and an SGLT2 inhibitor, but probably is not that huge as it is in the Western world. So what they suggested, published very recently, if you can see, just December 2023, just about last month, they are suggesting this article advocates adopting SGLT inhibitors as a primary treatment choice for treating patients with newly diagnosed type 2 diabetes in India. I don't know how many of you will agree to that. To me, I think it's again an unnecessary debate. I will not be using a single agent, be it metformin or dapagliflozin. I will be using a combination. So use both agents together along with other diabetic and anti-diabetic agents, because with using a metformin and an SGLT2 alone, you may not get glycemic goals. So we need a paradigm shift. We need to use combination therapy, and I would be using metformin together with an SGLT2 inhibitor. GLP-1, if they can afford it, I'll show you what my combination concept is. And this is what we wrote in this chapter in Professor Sadiko's textbook on the chapter on combination therapy. Depending on the baseline HbA1c, if it's very high, of course, you have to give insulin. But if it's 7.5 to 9, you would think of triple therapy. And look what we are suggesting: metformin, SGLT2, and GLP-1RA. So yes, SGLT2 inhibitors should be inverted commas first line, but the first line should include a combination of therapy rather than a single drug. But what is the reality? You will find this very, very interesting. This is published in 2021, Diabetes Care. These are the two various large insurance bodies in US, Medicare and Clinformatics. Look at the 80%, this is 90%. Look at the use of metformin. This is from the year 2013 to 2019. Look at use of metformin, 80 to 84% all throughout 2013 to 2020 is metformin, despite the FDA change for empagliflozin for CV risk reduction, despite FDA label change of liraglutide for cardiovascular protection, and despite ADA endorsement of SGLT2 and GLP-1 as preferred second-line treatment for CVD. Despite all this, if you look, metformin is so high, next still is sulfonylurea. Then is insulin. These are three drugs I used when I was doing my training, and they are still being used so high. So we need a huge paradigm shift in moving from this age-old metformin, sulfonylurea, insulin. Look at how poorly GLP-1 and today's discussion of SGLT2, how poorly they are doing. SGLT2 is this, I can't get my arrow, there it is. The red triangles, how piddly 2% of the people are getting SGLT2 inhibitors. So in the last 1 minute, I would say that when a patient comes to you with type 2 diabetes, don't just think of glycemic control, think of blood pressure control, lipid control, rhythm of smoking, think about weight. Think about pathophysiology. So don't think about first line, second line, third line. Think of combination therapy from the very beginning and choose the combination well. If there is ASCVD, heart failure, high risk, or CKD, please have a dapagliflozin on board along with your other combination drugs. Metformin can be on board because metformin also gives cardiovascular benefit, as shown in UKPDS, that small trial. People without ASCVD high risk, again, combination therapy and affordability, depending on affordability, metformin GLP-1, metformin SGLT2, and if HbA1c is more than 7.5, metformin SGLT2 and a GLP-1 or a DPP-4. So in conclusion, please think of an SGLT2 inhibitor quite high. Don't think of, I will start SGLT2 one day. You start SGLT2 today if there are no contraindications, and we all know the contraindications: recurrent UTI, GTI, upper UTI, recurrent UTI. If they have EGFR, probably nowadays less than 20. If there is if this type 1 diabetic, if somebody is in hospital who is restricted on carbohydrates, then you will not be using an SGLT2 inhibitor. With that, I will end my talk and